I'd like to introduce Dr. Weinstock from St. Louis, Missouri. Thank you for joining me, Dr. Weinstock.
Oh, my pleasure.
Could you tell us when you first heard about LDN?
That was in 2005. There's a compounding pharmacy up the street, and they came over and talked with me about the fact that they have been compounding LDN for some time, and thought that I might have need for it. I talked to him a little bit about it, and my conception at that time, not delving deep into it, having the time at that point, that year in particular, was that maybe this was just a motility drug. Maybe there was an imbalance in some of my patients with opioid receptors, too much endorphins, not enough, altering motor function of the gastrointestinal tract. And I thought, well, this might be helpful for some patients who need therapy for constipation. And subsequently, of course, we have methyl naltrexone or Relistor, which, of course, reverses opioid-induced constipation. So clearly there is some context there in retrospect. But I did find one paper that looked at the migrating motor complex in animals, that low-dose naltrexone improved migrating motor complex, which was really an important facet of my treatment of small intestinal bacterial overgrowth. So in SIBO, or small intestinal bacterial overgrowth, which actually may underlie many different diseases and syndromes out there, including irritable bowel syndrome, fibromyalgia, restless leg syndrome, rosacea, etc., that we need not only to treat the overgrowth of the bacteria in the small intestine, but the motility disorder, which predisposes to SIBO. So if you have loss of migrating motor complex, you don't have a sweeper weight to clean out the small intestine, keep it free of bacteria and debris. And so I was looking for something other than what we had available, especially in those who failed the little available drugs for motility at that time. So only later did I really start to understand the anti-inflammatory properties of naltrexone. And in fact, inflammation has, especially since the mid-2000s and later on, has really been one of the watchwords of major changes in medicine, as is microbiome. So the two big things that are going on if you're on the cusp, inflammation and the microbiome. Sometimes they cross over, many times they do, but there are a number of events that occur in our bodies that are not well understood. People, just start treating with prednisone and biologicals without wondering, well, where is this inflammation coming from and how can we change it?
Interestingly, we had Dr. Jill Smith as a presenter at the conference we gave in Chicago last year, and she was saying that some of the people with gut issues found that LDN upset the gut, and they were then using sublingual LDN, so it actually bypassed the gut with the absorption of the
interesting,
which was very good. Have you come across sublingual LDN?
I've not, but that's an intriguing idea. I get some practical matters which I'm still working out with patients. Is it better to take in the morning? Is there less insomnia or jitteriness if you take it in the morning? Or should you try to take it at night? I have my wife, actually, who was treated for restless leg syndrome associated with SIBO and then treated with LDN afterwards, has done fantastically for 5 years now. She finds that if she takes the LDN a little too soon before she goes to bed, then she gets a lot of rumbling and gastrointestinal activity, which kind of made me think about the motility factor. But again, she never suffered from the bad dreams or insomnia. And I've emailed Jill Smith, and we've emailed back and forth because I wanted her viewpoints on my work in ulcerative colitis. And I published the first paper on ulcerative colitis in LDN. And she's, reported in her articles 10% side effects of insomnia would be the main thing. I've looked at side effects and published an article in a compounding journal, International Journal of Compounding Medicine, and there's quite a number of potential side effects that patients reported, and with a big spectrum, which I can reiterate if you'd like.
Mm-hmm.
But this issue of sublingual, I'm not sure. What's it going to change? What's it going to be different about it? But I'll keep that in mind. At this point, I'm just curious, your friends and own other patients that you know of, do you think that the tolerance is better in the morning or in the evening?
It's amazing the number of people who do actually prefer to take LDN in the morning, not only to eliminate the sleep issues, but there are some doctors out there who prescribe LDN for ME who feel that it actually gives the patient a bigger boost during the day by taking it in the morning. And I do know a few doctors actually with patients with ME who do double dosing as well, where they use the same dose night and morning, and it's a split dose. Because LDN doesn't stay in the system that long, the body sees it as if you took 3 milligrams twice a day. It doesn't see it as 6, it sees it as 3 twice a day, purely because it's not in the system at the same time. So there are lots of different doctors out there that are doing their own research as they go along, as it were. All very interesting. But as I say, there are many people who do prefer to take it in the morning than at night, even those people that didn't have the vivid dreams. I mean, I didn't have vivid dreams or sleep disturbance. I was quite upset, actually, because I wanted all these side effects, because I wanted to know that LDN was working for me, but I never noticed anything one way or the other.
Interesting. So we can work either way for patients, and I think that we just have to be flexible, knowing that their individual tolerance is one way or another. I've when I emailed Dr. Zagan saying, okay, what's the best dose in general? He said 4.5. That was the end of his email, the entirety of his email, and I'm sure he's extremely busy, but. So for anti-inflammatory, I've been using 4.5, but there are a number of people where it's too strong and you have to back up and really work up the dose very gradually.
Yeah. Now, when we first started the LDN Research Trust and began talking to these doctors around the world, it would seem back then, in 2004, most people started on 3 milligram and the dropout rate was quite high. Nowadays, people start on 1.5 and titrate it up. And we have found that there are people who do extremely well on LDN on 2 milligrams, let's say, and once they start to go higher than that, they don't do as well. It might affect their legs or stiffness and spasms. That's one of the things with MS. A lot of patients can't go higher because it increases the stiffness and the spasms. Yet, we were told before, that you've got to get to 4.5 to have the ultimate dose. But there are some people that, are never going to get to 4.5. It really doesn't suit them. But the lower dose does. So we know from experience over the years that you can take a lower dose and it be beneficial. It doesn't seem to be the higher the dose, the better the benefit, but what dose suits the patient best. There are a group of people with a condition called Hailey-Hailey's disease. I don't know whether that's a condition you've come across. It's blisters of the skin and it breaks out in folds. in your groin, under your breasts, but it can also all go on your back and things. And as I say, it blisters and then it gets infected, and these people are in so much pain. And LDN is working extremely well for these people, but trying to get dermatologists to listen has been quite a task. I'm desperately looking for a dermatologist who would come and speak at our next conference. That would be quite something.
I have one for you.
Really?
Yes.
Oh, yes. Well, we'll talk about that later. That would be very good.
Yeah. I have somebody with an open mind, thank God, who's actually trying to do some work with me for rosacea, and I spoke on SIBO and rosacea to the experts around the world in Bordeaux this past December. So he invited me there. So, it's exciting. And I'm starting to use LDN for rosacea that's not associated with SIBO too.
Mm-hmm.
So we'll see how things go in that area.
I mean, LDN, we always have to say, isn't a miracle drug or a cure, and it doesn't work for everyone. But it's certainly something for patients to look into that have autoimmune diseases or indeed cancers, and if they have an open-minded doctor, yes, to work with. Is there anything else you would like to add before we finish?
Let's talk about restless leg syndrome.
Mm-hmm.
Mentioned Durkheim syndrome.
That's one I haven't heard of. What is that?
It's a rare condition of lipomas that get inflamed and have severe pain. It's unknown etiology, and I have a patient with that. And I do want to also end with an interesting story of an MS patient who has simultaneous MS and Crohn's. So restless leg syndrome, potential reason why LDN may work. One is the central pain phenomenon. Two is reducing inflammation. And my research partner and I, Dr. Arthur Walters and I, found that of the 38 different causes for secondary restless leg syndrome, 95% are associated with systemic inflammation, and quite a number are also associated with bacterial overgrowth when it's tested, and a lesser number with iron deficiency, which is really thought to be the big key for it. But nonetheless, there are less opioid cells in the brains of people who have restless leg syndrome. And this is an autopsy study that he did. And so my thought was, well, if we give LDN, maybe what we're doing is increasing the receptors and the endorphins in the brain on the existing lesser number of cells. Maybe that's why it's helping. So it may reduce inflammation, perhaps on the level of the gut, and gut lining permeability issues may be a factor. But it may work in the brain by one or more mechanisms. And as I said, on LDN Science, those who have restless leg syndrome, you can read more about that. I have a patient with Durkheim's disease. It's a rare disease, but it's basically angiolipomas and lipomas that get inflamed, and it's painful nodular fat, and it can involve the joint or anywhere on the skin. And I've had this one patient. It also is associated with cognitive dysfunction and joint disease and other vascular disease and obesity. And LDN has helped this woman a lot. And also, interestingly enough, naltrexone is being used in combination medications for those who have eating disorders or obesity in general. So that's, yet another one of the spectrums that we need to think about. And then I have a fascinating guy. I did colonoscopy on this gentleman because he told me his father had colon cancer, and he had screening at age 40, and he's been suffering from MS for 10 years. And for the last 5 years has been on experimental medications and third-generation MS medications, and he's walked with a cane and, was disabled, significantly disabled. And so he did his colonoscopy, and I looked in the small intestine, and there, lo and behold, was asymptomatic Crohn's ileitis. So I talked to him about LDN, knowing the data for Crohn's disease well, and also a little bit about the data of the 4 studies for MS, which I then delved into later when giving lectures on LDN. And so I treated him. A month later, he came in and said that his MS was dramatically better. He used more with it. He didn't use the cane for much of the day. And then a year after that, which was 2 weeks ago, he came in saying that he was off of his cane for 8 hours a day and still was taking the other medication, the third-generation MS medication, but was dramatically better. And one day he made a mistake and took it twice a day, and he actually got a boost, extra boost, from the 4.5 BID. I said he could play around with the dose, although it empirically makes more sense using once-a-day dosing. But, there are individual variances, and as we discussed, I think you have to play with the dose in your own clinical practice. So I do want to say, wrap up and say that I've treated well over 500 patients with LDN. There's certainly side effects, and if you go to my website, www.gidoctor.net, I have copies of my publications on LDN, both for ulcerative colitis and treating general gastrointestinal disorders and the side effects thereof. Of course, in America, the FDA strongly watches us and says that we should not promote off-label use of medications even if they're FDA approved. So I'm saying that in general, if a physician prescribes medication on his own that's off-label use, that is legitimate and legal. And to learn more, it's worth researching this, ldnscience.org and your organization and other sources are available to educate the physician. And so many times, we learn from our patients. And so I applaud your organization, which you started and benefited from, both personally and obviously by helping so many other people. I greatly applaud you and think that doctors need to be open-minded and to be willing to hear from their patients and learn from them. And I will end with a quotation by Arthur Schopenhauer, a famous German philosopher. And it says, "All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. Third, it is accepted as self-evident."
Very appropriate.
So appropriate to LDN.
Well, thank you very much for sharing your experience with us.
You're welcome, and I wish you could.
I'd like to introduce